I don't have to say how proud I am and how happy I am to have all of you here. It's a privilege that I can have all my friends together in the same place in Montreal for 2 days. If I have to invite people that I love the most, the room is going to look exactly like it is. Therefore, it's going to be a great meeting with great science, great medicine, but particularly with great friendship. We have chosen, and this is just a formality, 2 chairs for each session that we have. The first session is going to have 6 papers, and the chairs are my good friend Julio Huerta-Zavalia from Cordoba, professor in ophthalmology, and Rui Proença, professor of ophthalmology in Coimbra. If Julio and Rui could go there. And we have 6 papers. We're going to give 10 minutes for each paper, 3 to 5 minutes for discussions. And I'm going to ask a favor. If you, when you come up here, can tell everyone who you are and when you were in the laboratory, would be wonderful. Of course, I remember all of you and remember precisely the years that you spent there, but it would be great if you tell us this. Julio and Rui, it's yours.
Thank you, Miguel. Good morning to everybody. In this first session, we will have the pleasure to receive Susan Wakehill with a presentation of expression of collagen 1A1, fibronectin, and laminin in human corneas. Dr. Wakehill.
So good morning, everybody, bright and early. My name is Susan. I'm a 4th-year resident in ophthalmology at McGill University, and I've been part of the McGill Ophthalmology Ocular Pathology Lab, I would say for the past 2 years, since the beginning of my residency. I've been quite inspired by Dr. Bernier. So today I wish to talk to you about our recent study that we performed entitled The Expression of Collagen 1A1, Fibronectin, and Laminin in Human Corneas. I have no financial disclosures to declare. So there has been, in the literature, one can find ongoing studies in establishing the expression of, altered expression of glycoproteins among diseased corneal specimens. In fact, some studies by Bistrom and colleagues found some altered expression of laminin within specimen that had keratoconus. Other studies, such as Turi and colleagues, found altered expression of laminin and fibronectin in specimens that had either bullous keratopathy, keratoconus, and so forth. Among the glycoproteins that have been recently studied in the literature, collagen 1A1, fibronectin, and laminin have been the ones that have gained the most interest. Indeed, we know that these glycoproteins are a component of the normal human corneas. We know how, for example, collagen 1A1 is a fibril-forming collagen that is found in usually connective tissues, such as the cornea, and is responsible for tensile strength. We also know that fibronectin, which is a multifunctional glycoprotein, which comes in multiple isoforms and responsible in cellular adhesions. Finally, we also know that laminin, which is known for its cross-shaped, where's my pointer going? Right here. The cross-shaped that is known for laminin is also a multifunctional heterotrimeric glycoprotein, which is also found in the cornea and is known usually to be found within the basolaminar areas where it gives its cellular adhesion functions. So yes, we know that these are components of the normal cornea, and we know that they could be alterly expressed in some diseased specimens. However, what's normal? How are they normally expressed? And to date, there has not been any study demonstrating their comparative distribution across the layers of normal human cornea. Hence, the purpose of our current study, which is to evaluate the expression of collagen 1A1, fibronectin, and laminin within the normal corneas of adult and pediatric specimen. You're going to see today the word normal is going to be highlighted very often. So we hope that this will serve as a basis for comparative means for future studies. So in terms of our methods to do so, first of all, we took specimens that were enucleated eyes that had underlying disease in the posterior segment. For the adult group, we took eyes that had melanoma in the posterior segment, whereas in the pediatric group, we took eyes that had retinoblastoma in the posterior segments. Of note, the anterior segments were unremarkable in both groups. We further then performed immunohistochemistry using a panel of antibodies against the multiple isoforms, and using a fully automated system, we were able to obtain the intensity and extent of staining within each slide. Once we had these values, we then calculated an immunoreactive score, which is basically the sum of the intensity and extent of staining. And we then further graded that score into 0, which represented negative staining, 1 to 2, IRS of 1 to 2, which represented weak staining, and IRS of 3 to 4, which represented stronger staining. In terms of our statistical analysis, we performed an ANOVA in order to see if there's any statistically significant differences in staining in the expression between adult and pediatric corneas, and also between the central and peripheral expression of these glycoproteins. Our sample size consisted of approximately 21 and 29 adult specimens, and approximately 9, 10, and 11 pediatric specimens. Some specimens, the groups are not equal because some specimens were removed due to inadequate staining. So interestingly enough, from our study, we were able to find that there was actually no significant difference in the glycoprotein expression between the adult and the pediatric corneas, and also between the central and peripheral corneas, which was a very interesting finding for us. We were then able to create a table including both groups, and as you may see in this following table, there's actually different in expression in these different glycoproteins across the various layers of the cornea. So if we go one by one, for collagen 1A1, we are able to demonstrate there's actually stronger staining within the Bowman and the stromal layers. In fact, as you may see in this slide, there's stronger staining of collagen 1A1 within the stromal area with an IRS score of approximately 4, which represents strong staining. If we do a higher magnification, you could further appreciate the stronger staining within the Bowman layer with, again, an IRS score of approximately 4. Moving along to fibronectin. Now, fibronectin was quite interesting. Although, as you may remember, we said that there was no statistically significant difference in the staining. Fibronectin was found to be stained in the epithelium, stroma, and endothelial layers. Right here. But if you note here, we wrote plus or minus, and we also note 1+/2 pluses here. Why is that? Again, these differences were not statistically significant, but we wanted to also show that there was actually slight differences noted in a few specimens. In fact, in some adult specimens, there was some weak staining that was found within the epithelium, whereas in some pediatric specimen, there was no staining at all within the epithelial layer, hence the plus and minus sign. Furthermore, moving along to the stromal areas, we found that there was stronger staining within the anterior stromal layers of the adult specimen, whereas this difference was mostly noted in the mid-stromal layers of the pediatric specimen, hence why we wanted to show them both in the diagram. But again, none of these differences were statistically significant. So as you may see here, in the pediatric specimen, there's slightly more staining within the mid-stromal areas of the cornea, whereas here in the adult specimen, there's further staining with an IRS score of approximately 3 within the anterior stromal layers of the adult specimen. Finally, when it comes to laminin, we saw that there's a weak expression within the epithelium and a slightly stronger expression within the endothelial layer. As depicted here, we see the weaker staining within the epithelial layer of laminin with an IRS of approximately 1 to 2. And here we see in the endothelial layer, sorry, I lost my pointer. Voila. So in endothelial layer, we see a stronger staining of laminin with an IRS score of approximately 3 to 4. So to conclude, we're actually excited to say that this is the first comparative study, the first study establishing the comparative distribution of these 3 glycoproteins across the layers of normal human corneas. As we discussed, we saw that there's actually no statistically differences noted between the adult and pediatric specimens, and so the findings are consistent across age groups. And therefore, one may perhaps think if we are to find any differences in a certain specimen, this may be due to an underlying pathological disease. So where do we go from there? Well, obviously we're going to the future, and depending on how fast you drive, it'll be either near or far. But all jokes aside, we're pretty excited with these findings because we hope to use it as the basis of a comparative means for future studies and allow us to compare normal diseased corneal specimens now that we know what normal is, and perhaps try to understand the pathogenesis of the disease, or either develop any possible therapeutic approaches to halt any disease process, or even use these values to know, oh, we have these, this is abnormal and this is normal, and if you have these abnormal expressions, then this perhaps may indicate that this is an underlying disease of keratoconus or so. So thank you all very much for listening, and thank you for your patience.
Thank you, Dr. Wakel. Is there any question from the auditorium?
Excellent work.
Thank you.
Is this a surprising finding, or is it what you expect known on the function of laminin, for example? It's in the epithelium basement, that's what you're finding. So everything that you found was kind of expected, or was it some surprises?
There was a slight surprise in terms of fibronectin, because we know fibronectin from the studies is usually a molecule that is mostly expressed in the context of any trauma to the cornea, which results in where there's evidence of scarring, and you need fibronectin with fibrin to come and fill up the gap of the scarred area. So we're surprised to find fibronectin in actually normal baseline corneas, which is an interesting finding that we're further would like to look into. In terms of laminin, there's different studies ongoing right now, and like I said, there's different isoforms of laminin, and some studies have been mentioning that different isoforms are even expressed in different diseases, and we hope perhaps to push our study to a different level and try to find out which isoforms are more particularly expressed. Yes.
Do you know if this is age dependent?
Microphone.
Sorry?
Is this age dependent by any
Well,
Do you know yet?
In terms of the findings, if it's age dependent, or, well, given that the findings are pretty much equal between adult and pediatric corneas, we believe that perhaps there is no age dependent difference, if I answer correctly. Does that answer your question? Sorry. Yeah.
Dr. Susan,
Yes.
there are some results in corneal pathology already, or not?
Sorry?
Some results in corneal pathology?
In corneal pathology? Well, we're
Not
gonna,
yet?
For in disease specimens?
Yeah.
Yeah, we're further evaluating. My colleague, Dr. Marcelo Sobrino, is evaluating actually the expression of these molecules within the keratoconus specimen. And this is, like I mentioned earlier in the background slides, this is actually one of the reasons why we wanted to know what's normal, given that we were finding some abnormalities in abnormal corneas. We wanted to know what's normal. So it was, we were inspired by my colleague's study in order to perform this one. Thank you. Good. Perfect. Thank
Any
you.
more questions? So we are moving to the next one.
Just go.
Presentation.
Presentation.
Dr. Susan, for you.
Oh.
And I look forward to hear about Zika virus. And Dr. Vasco Bravo Figo is going to present about Zika virus. We have some cases in Portugal, imported, and I am curious. Please.
Yeah.
Good morning, everybody. First of all, I'd like to thank the opportunity to present our experience in Zika virus infection. I'm Vasco Bravo Filho. I'm from Brazil, Recife, Pernambuco. I was in the lab between 2013 and 2014, where I spent one of the best moments of my life. It's never too much to thank what Dr. Brunet do for us, and thank you very much. So I changed a little bit the title of my presentation, since we had, like for Zika virus, we have constant updates with new things that we are seeing in our experience. So I'm going to present some ocular systemic findings associated with prenatal Zika virus infection. We are now naming congenital Zika syndrome. I'd like to thank Camila Ventura for giving me some of these slides, and also thanks the support of Dr. Mauricio Maia, Eliane Ventura, and Rubens Belfort for all the support. So I'd like to acknowledge all the team of the Deltino Ventura Foundation. We can't do this alone, so it's a journey that we are passing through, so we need a big team and big institutions to support us as the Federal University of São Paulo. So the Zika virus, the flavivirus, as the dengue fever, yellow fever, West Nile virus, was first isolated in monkeys and the Zika forest in Uganda in 1947, and was first isolated in humans in Nigeria in 1954. The transmission cycle, like the mosquito bites the animals and then bites the human, and then start the cycle. There is also the proofs that can be transmitted through sexual intercourse, blood transfusion, and we're going to see in utero also. Basically, the symptoms are headache, painful red eyes, itching, rash, joint pain, fever, and muscle pain. Basically, we can do the diagnosis by laboratory in acute with RT-PCR between 5 and 7 days of symptoms, or post-acute with ELISA. There has some troubles on the limitation because of cross-reactivity, can be positive for Zika, but also can be a cross-reactivity with dengue fever. Or we can do the plaque reduction neutralization test that can differentiate the different flavivirus. However, there are some limitations with cost and the time to have the results. So was first documented in monkeys in Uganda. We had all the outbreaks through the time, and the most recent one was in 2014-16 in Brazil that spread through the Americas. After May 2015, 20 countries in America had a description of having Zika. The United States described it as a global emergency. And the outbreak in Brazil in April 2015, we had the first autochthonal transmission, and in October of 2015, started to analyze that was unusual increase of microcephaly in the country. So, and in November 2015, we could prove that the PCR was confirmed through PCR, confirmed Zika virus in infants with microcephaly through cerebrospinal fluid. So some data of microcephaly in Brazil. So the Ministry of Health, this is April now, so we have 1,198 confirmed cases. 194 are positive serology for Zika virus. It is present in 22 states, and 91% is present in the northeast region of Brazil. Sorry, and the northeast region is exactly that area, and Recife it's here. So our experience, like in Pernambuco, we have confirmed 1,098 cases of microcephaly. We are in our province is the one with the biggest number of cases. Cases under investigation are 2,671. In the first moment, like definition of microcephaly was below or equal to 33 centimeters, and after that, we realized that a lot of kids actually didn't have microcephaly, and so the criteria was decreased to 32 millimeters. And because of these other two are under investigation of microcephaly, if they have really microcephaly, or if they have other condition. And when we talked until February of 2016, what we usually use the term was presumed Zika virus infection. So we excluded all the torches, and the kid had microcephaly, so we're saying that they had presumed Zika virus. But in February, after February 2016, we had also like the ELISA confirmed in cerebrospinal fluid, and we could confirm and say that really these kids had Zika virus infection. at our experience at Altino Ventura Foundation, we started seeing these kids in December 2015. And in December and January, we examined 128 infants and the mothers. From those 128, we could perform the ELISA in 69. 63 were positive for Zika, 6 were negative for Zika, and 29 are still under investigation. But until now, the last update, we already examined 249 infants with microcephaly for Zika, and some under investigation. So from the 63 that were positive, 49 had microcephaly, 14 didn't have microcephaly. From the 14 that didn't have microcephaly, 12 had calcification in CT scan. That is a very important condition because the calcification in Zika virus are different from other conditions that also can give microcephaly, calcification as CMV. And from those 14 that didn't have microcephaly, 1 had ocular finding, even without microcephaly. So we were the first group to publish in the world at Lancet, like the first 3 cases of Zika virus associated with microcephaly and ocular findings in the world. After we published at the Brazilian Archives of Ophthalmology, a series of 10 cases, and it's this that I'm going to talk a little bit now. All had cerebral calcification. From the 10 mothers, 7 had symptoms of Zika. None of them had serology. Since I told you, like, the serology is important, like the PCR is the 5-7 days. And in the beginning of the outbreaks, nobody was taking care of this. Nobody was thinking and asking for serology, since as dengue fever was an auto-limited disease, and nobody knew that we were going to have all these problems. So the symptoms were rash, itchiness, arthralgia, fever, malaise. And from the 10 infants, 20 eyes, 17 were affected with some kind of finding. So basically, what we see, we have pigment mottling. You can see that the pigment mottling can vary, can be like slight, small, tiny, or can be a little bit gross and bigger, as in this other picture in your right. We can have chorioretinal atrophy that can vary from small, as those pictures show, in the macular region. We can have the medium size of chorioretinal atrophy, well delimited. Can be medium large, and all in the macular region, or can be large chorioretinal atrophy at the macular region. And those kids have the vision affected. We are undergoing other studies. All these kids are being treated in the rehabilitation center of our institution. And we hope that in 6 months or more, we're going to have more data about how the vision is impaired and how the therapies for rehabilitation can increase or not the quality of life, the quality of vision. Also, we can have a colobomatous chorioretinal atrophy. We not see only the atrophy, but we can see, like exactly as the name says, a colobomatous lesion. We observe also the optic disc hypoplasia. And when I always talk about optic nerve findings, it's how important is the RET cam for residual disease pathology. We had a RET cam in our institution, and some of the changed the findings we only could see after the analyzing well the RET cam, because sometimes it's tough to you see those kids, they're screaming, they have a high rate of irritating, they cry all the time, so they have imperceptibility, they have the tunnels of the muscle are very hard, so sometimes it's difficult to examine, to do the fundoscopy of those kids. And also we can have some kids with the pale of the optic nerve, as you see here. Other findings, like we have cranial and cerebral malformation, we have the redundant scalp scan, the calcifications. That is, if we're CMV, it were periventricular, so it's in the cortex, it's different calcification type as CMV. All the kids had a high rate of irritability. They have also strabismus, limb anomalies, clubfoot, autogryposis, and hearing loss also. So it's a real syndrome, a new syndrome that we are taking care. So the most important, I think the most important slide is this, the rehabilitation process. Like, if we just examine these kids, identify the disease, but we don't do nothing, we're not doing anything. So thanks God we have a rehabilitation center at our institution. Unfortunately, just part of those kids are going to be able to be treated there in all the country because Brazil doesn't have a structure for this. So it's important because we're going to work with all the deficiencies that the kids have, the limb anomalies, ocular, hearing, and intellectual. Because all the rehabilitation process for the treatment and the therapies are for life. And as soon as possible you start, as soon you're going to try to decrease all the impact of those findings in the vision, in the quality of the life, not only of the kids, but of all the family. I would like to thank you, everybody, for the opportunity.
Any question?
You have a question?
Very, very good presentation. Congratulations, and also a very important issue at present. One question from an epidemiologic point of view: is there any explanation about this outbreak in Brazil?
Look, the mosquito that transmits the Zika virus is the same one that transmits the dengue fever. And dengue fever is in Brazil forever and for years. So one of the hypotheses is that during the World Cup, the Zika virus came in Brazil and spread through the country. The northeast region, the problem of the mosquito is that it accumulates in water. So in Brazil, a big part of the population that have access to water in your house, so they have to accumulate water, big place with water. They usually don't cover, so it's easy to spread. So the explanation is it already had all the environment ready to spread through the country, and mainly in the northeast of Brazil. We still don't know exactly why, for example, Pernambuco, my province, is the one that has the biggest number of cases. We don't know if it is because maybe we are underestimating. We know that increased the number of microcephaly, but for sure, before this, we underestimated the number of microcephaly because the data from Brazil before the Zika virus appears showed that the rate of microcephaly in Brazil was lower than US. That probably is not true, but probably now we are underestimated for sure. But I think the explanation is due to that, to the World Cup, and brought the virus. Mm-hmm. I don't know if any other Dr. Belfort has, probably he's going to talk also tomorrow about the... Mm-hmm.
I agree.
Yeah.
Vasco and his group are doing superb work there. They have hundreds of children with microcephaly. They're going to live probably for 60 years, not a suffering. Many of these mothers are teenagers, so can you imagine the nightmare? And frankly speaking, I don't think rehabilitation will make much difference because these kids do not see, they don't hear, and they have no brain. So it's going to be a terrible, terrible situation, getting worse at any moment. And they're struggling there, and superb work. They are providing excellent scientific information. We have another paper now under embargo. It's going to be out in the JAMA May 26, and other papers coming. And again, it's amazing how good work they are doing there.
It is good to emphasize that, as Dr. Belfort said, those kids are healthy in the systemic point of view, so they're going to live long time for sure.
It's something like toxoplasmosis.
Sorry?
Is something like toxoplasmosis, healthy children with retinochoroiditis. And the other thing that I wanted to know is, it's a chorioretinitis or a retinochoroiditis?
No. We didn't get any inflammation, just the chororetinal atrophy. We didn't have any case, at least in Recife, we didn't see any case with acute inflammation or something like this. Yeah.
All the lesions temporal to the fovea?
Yeah. No peripheral lesion.
There's a reason for it, do you know? Why that is the location?
Sorry?
Do you know why the location of the lesion is temporal to the fovea?
We still don't know.
So the explanation is something called torpedomaculopathy. And during the eye development, temporal to the macula, there is outpouching of RPE. That has a different closure than the natural plant. And sometimes you can get this tropical-like horizontal oval lesions temporal to the fovea. The nasal edge right at the fovea is the classic location. There is an embryologic thing, and we maybe talk about it later. This RP outpouching that has a different regression and guidance.
Thank you. Perfect.
It seems that also related to the real time of the infection. And probably the virus inside the cell capture all the energy that would be necessary for the gene to express. So there is no information, but it's lack of expression of a gene. So the viral would work like a suction mechanism, avoiding the energy to be available at the gene to express itself. It's a fantastic puzzle that the medicine now is trying to understand. What we do have in Bahia some cases more at the periphery and with the macula not involved, but most of the cases, like Vasco said.
Jim has a question, but before Jim has a question, I have an information and a question. This is a microphone. We have two possibilities. Either Tiffany's going to run around the microphone, actually three. Second is Tiffany's going to hold the microphone right here, or we're going to have this stand. I think it's better. Question to you, Vasco. Is there, come here, Jim. If you look at clinically, and you showed extremely nice pictures, and perhaps there's other things that are going to come up, OCT and all this. I know that kids are the very, very babies, but that's fine. Those clinical findings are diagnostic, very, very conclusive, or pathognomonic of Zika, or because they could perhaps be similar to a lot of other conditions.
Yeah, because of that, we like in all the cases, we at least we excluded all the torch syndrome. So, but for like 80% of the mothers also can be asymptomatic. So for Zika, so it's the problem mainly in Brazil. Like we don't have good access to the laboratory. So if you could have laboratory for all of them, we would have answers like faster than we have now. But isn't it specific? Like, there is no pathognomonic. If you have rash, if you have itchiness, it's has a high probability to be in Zika, but it's not pathognomonic.
Thank you for the excellent presentation. I have a question on the most severe anomalies that would occur in the first trimester. But have you been able to determine if the pregnant woman is infected in the second or third trimester? Is there a stratification of these defects? Is there a change in the pattern, and what would that be?
Yeah. We have a lot of data that we're analyzing, so we don't have completely answered, but it seems that there is, as you said, Liz, as soon as the infection is in the beginning, we have more changes than when the history of the infection is in the third trimester, for example, after 4 months. So after 4 months, usually the findings are less aggressive than the one that are in the first 4 months of pregnancy. Thank you.
Thank you, Dr. Vasco.
Thank you, Dr. Bravo. Next talk will be Dr. Brian Arthurs. He will talk about mucinous adenocarcinoma. Dr. Arthurs.
Thank you very much, and thank you very much to Miguel Bernier. I've had a nice collaboration with Dr. Bernier and with many of the people in the room over the years. I've never, unlike everybody else, there are many people here, I've not spent a year in the ocular pathology laboratory, but we all know how popular Miguel's fellowship is, and so I am slotted in for 2023, and I look forward to my spot in your place. I've already sent it in. She's told me 2023, and so if somebody bows out before, then I'll be there. I have no financial interest. About 20 years ago, I saw, maybe more than 20 years ago, I had a very interesting case, a 67-year-old man who presented with a recurrent cystic lesion in the right lower lid. He had had a previous excision about 5 years before. I don't know who did it, and there was no pathology performed at that time. So when I saw him, he had almost a bilobed appearing lesion that transilluminated. There were no nodes present. And I excised the lesion and sent it to pathology. And I just wanted to give you a picture of him. And this is what it looks like here with the, I guess this isn't working too well. Sorry about, oh, here we go. Just with this sort of bilobe lesion transilluminating, and just another slide here, closer view. So I got the pathology back. There we go. And in fact, this was a malignant lesion of sweat gland origin, and I had, up to that time in my practice, never seen that before. So I returned the patient to the operating room, and we did a complete excision of the tumor. We did frozen section control, and the margins were free, and then we did a lid repair. And just because here we are with a gross specimen, about 13 millimeters, and we can see it's sort of, there are different lobules to this thing. And we look at the pathology here, and I want to thank Dr. Bernier and Pablo especially for providing me with all these slides. But here, top left, we can see very nicely preserved epithelium. This is very normal, but very abnormal dermis. We've got these accumulations of cells here in this mucin type of background. On a little bit higher power, top right, we can see that there's an aggregation of these cells. They're polymorphic and hyperchromatic, and there's some mitotic examples in there. And down here, the cytokeratin stain is very positive, and the gross cystic disease fluid protein is also positive here. That's like the breast too, so illustrating that it is has a glandular type of adenocarcinoma. And here, just showing the patient, because you probably don't see too many slides like this. So here's just what the patient looked like immediately after the excision. We did a reconstruction involving the upper lid as a two-stage procedure, and then we opened it up, divided the flap 8 weeks later, and this is his final appearance. So just a summary of the path findings in this case were tumor infiltrating the dermis. The epidermis was not involved. We noted cohesive cells with polymorphic hyperchromatic nuclei and mitotic figures, and positive for CK7 and GCD-FP, confirming adnexal origin. So case 2 was a 73-year-old man with a right upper lid lesion that he'd had for about a year or so. It was gradually enlarging, and it also had this sort of multi-lobed type of appearance that transilluminated. There were no nodes. And as soon as I saw this picture, I realized this is the same thing that this other guy has. So it really has a very distinctive type of appearance. It's just this multicystic thing that we wouldn't normally see in other lesions. And so we took him to the operating room, and we excised an 18-millimeter piece of full-thickness eyelid. Frozen section control showed negative margins, and we sent the main specimen to pathology and did a right upper lid repair. So here's the specimen measuring about 18 millimeters. But I looked at this and I said, you know what, I just have to see what's inside, because I remember the first one that I'd removed, I opened it up a little bit, and there was this very sticky type of mucousy material. And so I opened it up here, and it's got really a multilobular type of structure. It's very distinct, and we don't really see that in other types of pathology. So it was very interesting to me. And here, fairly similar type of pattern. We see the epidermis is nicely preserved. We see that the tumor is extending into the dermis and involving the skeletal muscle. Here we have these cohesive cells, again, polymorphic, hyperchromatic with some mitotic figures, and highly positive for cytokeratin and GCD-FP. Here we go. And so this is his defect, and we repaired him with a flap from the lower lid. We call it a Cutler beard flap. We divide the flap in about 8 weeks, and this is at the time that we separated the flap, and his appearance about a month later. So pretty good function of the eyelids. And case number 3 was more recent, a 67-year-old man with a lesion that he'd had for about a year. This one appeared kind of pedunculated, I would say. It was 7 millimeters. It had an unusual appearance. I had no idea what it was really, but I excised it and sent it to the lab. And I have to say I was really surprised when it came back with a similar type of diagnosis. So here we can see this lesion here, almost not exactly on a stalk, but certainly well elevated from the surrounding skin. So again, the pathology noted a mucinous adenocarcinoma, and we took the patient back to the operating room just to make sure that there was a clean excision of the tissue surrounding that area to make sure that there was no residual tumor. And again, we'll see a similar pathology, preservation of the epidermis. We see these tumor cells floating in the mucin, and similar pattern here with the cohesive cells. Very strongly positive staining for cytokeratin and the GCDFP or breast2 type of staining here. And here we have a duct that has a much infiltrated area of tumor here, and on the P63 we see that the myoepithelial cells are staining. So in summary, we presented 3 cases of mucinous adenocarcinoma. Very similar clinical features in the first 2 cases, a little bit different in the third case, but all 3 cases had very distinctive histopathological findings. And so in conclusion, mucinous adenocarcinoma is really a rare tumor. There is a potential for metastasis from this tumor and possibly death. However, early diagnosis with a full-thickness biopsy and appropriate surgical management really gives a very positive prognosis in the great majority of patients. So I'd like to thank you very much.
Thank you, Dr. Arthurs. Very nice presentation. Do you have any questions? Dr.
Please.
Bornier,
Brian, but I have a question to first Jim.
please, the microphone.
Jim, where's Alex? Alex, and where's Abraham? He's here. How many cases of this have you seen?
No.
None?
I've seen 3.
3?
3.
See, that's what happens in Ontario. He said.
That's
I saw 3. 3?
3.
Identical, similar.
Well, actually, I was going to bring up a very important point, and I think this is a great talk, Brian. I've seen 2 very classic examples. The third was a shave biopsy of what, because these things look like hydrocystomas, especially small ones. And a shave biopsy was done, and the shave biopsy was interpreted as a proliferating apocrine hydrocystoma. And actually, the rim did look, I reviewed this case, and you know, in retrospect, it was clearly a mucinous from the beginning. 2 years later, it recurred, unequivocal mucinous adenocarcinoma. So my caveat is if you have these hydrocystoma-looking like lesions that are a little atypical, please do a full biopsy. If you get a report back that says proliferating apocrine hydrocystoma, that's a very difficult diagnosis in dermatopathology to make. Your things should go up because, interesting, mucinous adenocarcinoma, the most common site in the human body is the eyelid. And every time you get these cases, of course, we have to rule out a GI origin, or if it's a woman, a breast origin, just because you can't be 100% sure, even though pretty much it is a primary in the eyelid.
Yeah. I guess the only other thing I would say is that the first case where I found that the mucinous type of secretion, I've never seen that in another type of lesion. So if I would ever be doing a cyst and I see that type of thing, it's going to really ring a bell, and I make sure that I would take out the whole thing.
No, not on the skin, on the eyelid. But congratulations for the presentation. I just want to point that we have mucinous or colloid adenocarcinoma, as we call, in other parts of the body. For example, in the colon, it's not so rare. In the skin, it's really rare. But in the colon, in the breast, we see kind of frequent. And they have kind of different implications. For example, in the colon, when you see something like that, you have to rule out syndromes, especially Peutz-Jeghers syndromes or non-polyposis familiar colon cancer. The breast, usually, they have a good prognosis compared to this normal ductal carcinoma of the breast in terms of size, and that's because the quantity of cells If you measure the tumor, the quantity of cells is less because of the mucin that is there. But on the other hand, it's more difficult to achieve a good margin because of the mucin, and so need a great exhibition. Do you have any syndrome or something in this case? Because they are really rare in the skin. I'm not sure if they're associated with any other kind of syndrome or tumor elsewhere. And then, of course, the immuno helps in terms to differentiate from metastasis or not. Yeah. This one in colon, it's CK7 negative, CK20 positive. This is on the other. This is the CK7 positive and CK20 negative in the skin because it's an axo.
I'm not aware that it's associated with any syndromes, Alex.
Okay.
And there were certainly no other syndromes that any of these 3 patients that I saw had, that's for sure.
I have 4 or 5 examples at my lab. And from the histopathological point of view, in my experience, very useful stains for this tumor maybe are the PAS stain and the colloidal iron, Alcian blue, very helpful because those lesions have a lot of mucin. And the cells are very innocent cells sometimes because they don't have a lot of mitotic figures, atypia, pleomorphism. They are very innocent, and sometimes the pathologists don't recognize those findings.
Just to tell you that the kids in biopsy, they grow up. Abelardo Rodriguez is the pathologist at the largest institution in ocular pathology in Mexico, and Alex Wadershir is a professor at Laval University. They grow up, they don't tell me, but they grow up. Jim has 3 cases, Abelardo has 5, that's 8 plus 3, that's 11. The lab also has another thing now, has a dermatopathologist. Where's Denise? Where do you see that elsewhere in the skin? Extremely rare. Would you say, Jim, this in the eyelid is the most common location? Then the thing that I'm going to say to you is, a week ago, I received a letter from Dr. Buttany. Dr. Buttany is a cardiovascular pathologist in Toronto, and he's the editor-in-chief now of Human Pathology Case Reports. For the first time, a very good journal like Human Pathology decided to have a special wing of, or branch of the journal, to publish case reports and case series. I think we should take advantage of that, perhaps, in the name of biopsy, put cases together and send to human pathology, because this is extremely interesting from the clinical point of view. As Brian said, you can make the clinical diagnosis most of the time when the presentation is traditional. From the pathology point of view, Abelardo brought a very good point. Cytologically, those tumors, they look less malignant than they are. Then this, as Jim pointed out, perhaps poses a problem with differential diagnosis for pathologists. I think if you put our cases together, this is going to be a very strong presentation. Thank you, Brian.
Thank you very much.
Let's move to the next case, next presentation by Luís Frederico Pacheco, a case of choroidal osteoma.
My name is Luís Frederico Regis Pacheco. Everyone calls me Fred. The first time I went to the lab, it was in 2011 as an intern, and Dr. Bernier helped me a lot on my evolution in ophthalmology. It's awesome to be here. It's great, the invitation, doctor. Thank you a lot. So the case today is about a 32-year-old female. Her chief complaint was that her left eye was foggy. She came telling that she had a progressive worsening of her visual acuity of the left eye in the last year, and now she was even worried, more worried because of the blurred vision of that eye. And she had no previous ophthalmologic evaluation. She had no previous medical history or family history. Her eye exam, her best corrected visual acuity was on the right eye was 20/20 and the left eye 20/50. And on the exam, she had only the anterior blepharitis, but no lenses opacities or no anterior vitreous opacities, normal IOP, and she had an Amsler grid test positive for the left eye. She had metamorphopsia. So the eye fundus of the right eye was completely normal, and on the left eye, she had a huge lesion, subretinal lesion on the macula, was well circumscribed with yellow and white with some areas of hemorrhage. Oh, where am I? Okay, here. So we started thinking about, just to compare the eyes, but we started thinking about the differential diagnosis and all the differential diagnosis over there. And we stayed with choroid osteoma. But why? Why choroidal osteoma? On the exams, the B-scan ultrasound with the high frequency, it showed us that hyperechogenic lesion over here, even making a shadow beyond the lesion. And a characteristic of the choroidal osteoma is that when you lower the frequency of the ultrasound, it's still hyperechogenic. So before that, we made the OCT, and that how do I say it? Oh my God. This paper helped me a lot with the characteristics of the OCT. The characteristics of the OCT, by that 15 eyes with choroidal osteoma, that they show the horizontal lamella in 100% of the eyes. Those hyper-reflective horizontal lamella, the semen lines, the horizontal tubules, and the vertical tubules. And our patient had everything. So we can see here the bone lamella, the semen lines are hyper-reflective, and the tubules over here. On the fluorescent angiography, we made a red-free before, and we can see the lesion over here. And on the early phases, you see that hyperfluorescent blockage here on the choroidal flush, and it started going hyperfluorescent on the side of the lesion. And that made us think about a neovascular, choroidal neovascularization, and we say, what to do now? So I Googled it, and another paper that showed us a good end with antivascular endothelial growth factor therapy, and that's what we did with our patient. So 2 months later, after 2 injections, she had 20/20. But the thing is that this exam, the autofluorescence, is the exam that predicts the prognosis of the patient on the choroidal osteoma. But why that? It's because the main process of the lesion is that it deossifies, which injuries the photoreceptors, and that's why the visual acuity of the patient lowers. But our patient, you can see here the suffering of the RPE, so the prognosis is not that good. And okay, happy ending, but when I was in the lab, Dr. Bernier always told me that when you see something rare, you're going to see it again soon. So 1 month later, another patient came to us with this lesion, and we made the diagnosis of choroidal osteoma also, and with neovascularization of the choroid. And after the injections, the final lesion, and it was a good end for the patient also. So that's it. Thank you for your attention.
Thank you, Dr. Luis. Any question? Miguel.
Yes or no, which is impossible, but I know. OCT, pathognomonic or no pathognomonic?
I think it's very difficult. Very difficult to say that. I was going to ask if there's any chance we can evaluate the vessel, OCT angiography.
That's what I was going to say. Yes, OCT angiography.
I mean, it would be fantastic to see it because then it would say, it could predict a little bit the progression of the disease, including if the vessels, how is the branching pattern of the vessels in osteoma, which has never been shown or published to the best of my knowledge. I think it would be really interesting to, if you are able to have the technology like that, to assess that not only the vessels are related to the disease itself, but the side effects. So how the vessels progress through the membrane, proliferation and so on.
Yeah, unfortunately, we don't have that in Rio.
Go ahead, please.
So I think OCD, we are over-reading into it. We don't know what we are seeing, and there's no correlations. You can describe those lines, we don't know really what it means. So diagnosis with ultrasound or clinical...
No, sure. I just made the OCT, but...
Yeah, I understand. The issue really is of the complication of a neovascular membrane, which is the most frequent complication of
Yeah.
And did you ever consider PDT for the diabetic therapy?
Yeah, that article that I read, they made a lot of they made the PDT and with injection, and we didn't think about it because in Rio we don't have that much access to PDT. But on the article they had good results with it.
We think PDT would be better than...
Yeah, because it's one-time intervention. With injections, you may have to
Yeah.
do so many.
And for all of you to understand, we're not treating the tumor, we're treating the complication of the tumor, which, by the way, is a completely different story.
Yeah, sure.
OCT is interesting insofar as you can sometimes see calcification, decalcification components as this tumor changes. Several years ago, we tried to treat these tumors with dye laser orange wavelength light, and had some successes in terms of stability, but they can be obviously very difficult with the newer sensation of the anti-VEGF issue. It's much different.
Yeah.
But certainly they can be bilateral, as you know, and they can be quite progressive.
Yeah.
Okay, David, sorry, there's a young man behind you. His name is Carlos Moreira, right behind you. His nickname is Guto in Portuguese, Guto in English. And he just put together with the OCT, Anfas, and stuff sorts, a instrument that we're not going to tell you what it is because probably it's a patentable thing. We're going to patent that. It is a box where you can obtain images from OCT that are absolutely spectacular from IDEC eyes, as well as we can obtain the histopathology precisely in this section of the OCT. This PhD thesis is a fantastic work. For the first time, we have a perfect correlation, and I totally agree with Dr. Singh that unless we have that correlation absolutely precise, sometimes, besides a very Romano that knows everything, we're saying things that are not true. Sometimes, besides the Romano, sometimes we're exaggerating and going too far in things we believe we're saying. And the OCT correlation will be perfect.
Okay. Thank you, Luis. We move on to the next talk, Vitreous Seedings in Retinoblastoma by Maria Eugenia Orellana.
Hi, good morning. For me, it's a pleasure to be here. I am María Eugenia Orellana. I come from Caracas, Venezuela. My first time in the lab was in 2006, and then I came back between 2008 and 2009 for a year at the lab. I think, like my son said, was our best year in our lives. And I'm going to talk about retinoblastoma. That is my line of research. And remembering, retinoblastomas are any type of tumor dispersion of this tumor into liquid, adjacent liquid, and to any compartment inside the eye. Also, seeding is typically seen in advanced retinoblastoma and represents an important determining for eye grouping at presentation. The seeds could go to 4 different anatomic sites and are vitreous gel, also the retrohyaloidal space, subretinal space, and also to aqueous fluid. The types of seeding were described as 3 different types that are dust, spheres, and also the clouds. In Venezuela, sadly, the majority of cases are diagnosed in advanced stages. So at that time, they have no possibilities or few possibilities to treatment during that time. And sadly, again, the most common treatment of choice is enucleation. Clinically, the physicians look about from 1 to 5 new cases a month, and between 12 and 24 for a year, and majority in Group D. Of 10 cases, approximately 8 of them are treated with primary enucleation due to the advanced stage. That occurs because late diagnosis. Second, because we have few information for clinicians like general physicians, also general pediatricians, and also the parents, relatives, and the population doesn't know about this tumor. Also, the parents trying to find more opinions before start treatment, and it takes more than 1 year to go to the oncologist. In our institute, we have a ocular pathology laboratory, and it's at Instituto Anatomopatológico. Between 1960 until last year, we had 658 eyes. And in the last 5 years, approximately 107 cases of enucleation. The object of this work was to compare the identification of retinoblastoma seeds on that cases with the evaluation, the REDCAM evaluation report made of ocular oncologist. We compare what they look at the REDCAM with our findings, and we studied 22 cases, all of them in almost all of them of 2015, and we have 22 eyes of 21 patients. The mean age was about almost 2 years of age. Male are more than the females, and we have equal the same of eyes. Primary vitreccidents were were 18 cases of 22, and secondary due to the treatment 4 cases. Clinically, the ophthalmologist described those 3 types of sedents that I told you about: dust, spheres, and also the clouds. It's not, in some cases, we can compare what we see at the slide, and here we have a small group of cells here in the vitreous. Also, at more magnification, we see small groups that call dust in our slides. Also close to pars plana, here's the vitreous base, and also here we have more structures called as spheres. Also here, dust between the fibers of the vitreous, more magnification, we can see some cells that are viable, others are necrotic. Here, some areas of necrotic cells. If we compare those findings with this image, we can see here some dust, spheres, and also the clouds. Another cases of this group with more areas with spheres. Also here we can see dust here and also the spheres over the tumor and more advanced stage of the disease with the same structures here. If we compare, we can see the spheres. And in the histological slide, you can see the spheres, also necrotic tissue, more spheres, areas of calcification. And we try to compare what they look in the red cam with our findings. And here we see more clouds. Also here, adjacent to the areas of necrosis. Here is spheres with some areas with not functional cells, viable cells. These areas with the red cam with the spheres. Also here, like a starry sky, all the spheres that are in the vitreous. More findings of these patients. And here we see the clouds, look at they are more extended, close to the vitreous. Here, like a happy face, but these are spheres, clouds, tumor. Also here, there are more necrotic areas with the tissue that are arranged like spheres, clouds, more magnification of the tumor cells. Here the vitreous, now dust. Here the tissue is more, it's arranged with the tumor cells inside, more magnification. And in some areas they look over the pars plana, like here with more magnification, inside the vitreous, and close to the retina, and here the subretinal dust tumor cells, also inside the vitreous. And in the anterior chamber, we can see the cells, and here the pars plicata, here's the lens, and at the syn sonula, you can see the tumor cells. More magnification with tumor cells in dust, spheres close to the back of the lens, more magnification of the same group of cells. For that, we use the kappa coefficient, Cohen's kappa coefficient, which measures the agreement level between two observers, the clinician and pathologist. And we use that this formula, and we obtain this 0.273, and the agreement was considered fair. So we don't have any strong agreement between these two observers. The agreement level was low, and of course we need to precise clinical and pathological criteria to know if we are looking at our slides what they look in their patients. So that's the importance. Even the description of these structures was made to evaluate response to intravitreal drugs is useful to be characterized in the pathological report. And I think it's important for us as a pathologist to try to find your findings in our slides. And thank you very much for this opportunity. This is Caracas, this is our Avila, the Guaraira Repano, and this is Central University of Venezuela. Thank you very much. Thank you, Dr. Bonner.
Thank you, Maria Eugenia, for this very interesting presentation. Is there any question? Abelardo?
Few simple questions, Amaru. First, how often do you find the classical structures of retinoblastoma on the vitreous settings? I mean, the Flexner-Wintersteiner rosettes, Homer-Wright rosettes, are frequent in those settings or are?
No. No, normally we find the differential structures inside the tumor, and here the cells, normally those are sparse cells, and spheres, they are arranged with a necrotic center,
Okay.
and also the clouds are in a big like sheets of tumor cells.
Okay.
But not the differential structures.
Okay, and that's my other question. The vitreous seedings correlates with the amount of necrotic in the tumor, or are completely?
In my experience, most necrotic tumor produce more vitreous seedings because the tumor rupture the internal limiting membrane in some cases, and they go through the vitreous and also to go to the anterior and posterior chambers.
Thank you.
I think one interesting part of this work would be, Abelardo, to try to characterize if the cells that are producing any type of seeding. I'm going to take it back for a minute. In retinoblastomas, you have either the cells that are surrounding this leaf pattern that was described so many years ago by Dr. Zimmerman and co-authors, and those cells are incapable of invading the choroid, and those cells are incapable to invade the optic nerve. Therefore, we say if the tumor is intraretinal, the patient is going to be cured no matter what. Problem is the clone changes, and then the cells invade the choroid and the optic nerve. My question would be, are the cells that produce this seeding, any type of it, any morphology, similar to the cells that are not capable of invading, or they are invasive cells? I'm going to entertain the possibility that they are already invasive cells because vitreous seeding is a criteria for bad prognosis, and is a criteria in the new classification to place the patients in different groups. I think it would be very important to do immunohistochemistry studies or immunohistochemical studies on the vitreous seedings and compare to both the cells that are not invasive and the cells that are capable to invade. That would be very interesting. Perhaps more interesting than just to do the morphology.
Yeah, maybe if you mark with KI56, would be great.
KI67, KI67, or any other marker,
53.
or you do a immunohistochemical panel and then characterize the cells. That I think.
Good idea. Thank you. Another question?
Thank you, Dr. Maria Eugenia. Now the last presentation by Dr. Cristina Fonseca about immunohistochemical characterization of COX-2 in conjunctival melanoma. Cristina?
Hi.
It's a pleasure.
Good morning, everyone. I came to the lab in 2014. I've spent a month here in observership, and I have so much to thank to Dr. Bernier for the opportunity. I'm here on behalf of my coworkers, and I'm presenting this work, which is the COX-2 immunohistochemical expression on conjunctival nevi and melanomas. So, the thing about conjunctival melanocytic lesions is that they are the most common lesions, melanocytic proliferations in the conjunctiva. They are roughly a half of them, and for general pathologists, they are kind of difficult to maybe sometimes make the diagnosis because we can't apply the same features as we use in cutaneous lesions. So sometimes it may be difficult to differentiate, in some cases, malignant proliferations from benign proliferations, and this can result in misguidance of the management and prognosis. We thought that COX-2 could help us. So with COX-2 is an enzyme that is a synthesis form that produces prostaglandins. There are two isoenzymes. The COX-1 is very known, is a constitutive enzyme, and COX-2 is an inducible enzyme that responds to growth factors, oncogenes, and carcinogens. COX-2 has already been known to be expressed in epithelial tumors like esophageal tumors, gastric tumors, and the more known colon cancers, but also in non-epithelial malignancies like cutaneous melanomas and more recently the works here in the lab, the uveal melanoma. So the purpose of our work was to evaluate this expression of COX-2, but in conjunctival melanoma and nevi, and to see if there was any differential. There was an animation here. And the second point was to see if there was any differential expression between benign and malignant lesions in what concerns COX-2 expression. So we used 20 samples, 20 nevi and 20 melanoma tissue samples that were formalin fixed and paraffin embedded from our ophthalmic pathology lab from our Coimbra University Hospital. And our immunohistochemistry was performed in the pathology section with automated immunohistochemistry, and we used as positive control colon adenocarcinoma. We classified the samples as according intensity of staining and percentage of immunostained cells, so we could reach a score, which we graduated until 0 to 4. And the samples were analyzed by two pathologists from the pathology department. So, as for our clinical data, the mean ages were kind of the same between groups. There was a predominance for female patients, and most lesions were on the bulbar conjunctiva. As for immunohistochemical expression, 87% of all nevi expressed positive COX-2 staining, and for conjunctival melanomas, 94% expressed positive COX-2 immunohistochemistry. 62% of them with moderate or intense immunopositivity, and 66% of them with moderate or intense immunopositivity for conjunctival melanoma. So overall, more than 90% of them expressed positive expression for COX-2, both in conjunctival nevi or melanomas. When we tried to differentiate the groups among expression, we could not find any statistical significant difference between the groups because the expression was kind of roughly the same. These are some examples of that our pathology department gave us. They classified those as for an nevi. They classified as for an intense staining, score 4, and this for a melanoma as the score 4 as well. So we based on previous reports and the previous works. They have shown that there was moderate or intense positivity for COX-2 in more than 90% of uveal melanoma. And for the best of our knowledge, this is the first study to assess this expression, but in conjunctival specimen. And we found that more than 90% of melanocytic lesions expressed positively for COX-2, and more than 50% of them with moderate or intensive immunopositivity. So what is the role, the physiopathological role for COX-2? There is some animation missing here, but the thing is that based on previous works, we saw that the expression of COX-2 was related to histologic poor prognostic factors in uveal melanoma, and also with reduced survival rates and metastatic death. So COX-2 here, we know that it responds to and it's involved in cell growth, angiogenesis, invasion, metastasization. So there is a role here for the use of anti-COX-2 drugs. And it has been shown in vitro and in vivo that the addition of amfenac, which is an inhibitor for COX-2, also reduces metastasization in a uveal melanoma animal model and reduces proliferation in vitro. So as for conjunctiva, we thought it could be helpful to use this as a differential tool. However, and based on cutaneous specimens, we thought that these authors, they described 20% of immunostained cells, which they call the melanoma indicator, that could help us differentiate them differentiate cutaneous benign from malignant lesions. However, we could not find that difference, and for us, it's not possible, based on only immunostained COX-2 expression, we could not differentiate malignant for benign lesions. So we know that there are many limitations for our work. It's a small sample. We had some technical difficulties assessing the expression of COX-2 because we use the chromogen, which is a dark chromogen. We had some difficulties differentiating pigmentation from the chromogen coloration. But we know that it it raised some questions, like there is difference in the prognostic, going away from diagnosis. Is there a role in helping prognostics? And if there is, if topical anti-COX-2 drugs are helpful in conjunctival melanoma. So in conclusion, there's no conclusions because I don't know, but our conclusion is that COX-2 is expressed in both malignant and benign lesions, and that it cannot be used as, for our study as a tool for helping differentiating challenging lesions. Thank you. This is Coimbra, and I invite you all to go there.
Questions?
I'm going to make the same comment that was made in a paper that I wrote many, many years ago. It's extremely important to show negative results, including because then we don't have the tendency of doing again. We don't have to do it again.
Yeah, we
right?
save money.
Yeah, that's great. Yeah, we don't have to do it. There's two ways of avoiding the confusion with the melanin. One is you do immunohistochemistry, and then you bleach the slides and conserve the immunohistochemistry. Then the easiest way is just change the color. Don't do it with the brown and do it red or any other color. Interesting is the fact that the work does not indicate if COX-2 or anti-COX-2 medication is going to be good for conjunctival melanoma. Mm-hmm. That's important because we know, actually we don't, but we believe that COX-2 or anti-COX-2 medication has a role for uveal melanoma, and was Anderson Figueiredo, that's somewhere, who started that work. And in our cells, in our samples for uveal melanoma, that works. Then the fact that it's very positive, actually even more positive than uveal melanoma, it indicates to me that COX-2 may play a role in the melanoma cohort, in the melanoma patients of this. Then anti-COX-2 medication may be important to consider in the future.
No, we didn't, because the samples we used nevi, different nevi compounds and junction. We didn't even divide them in groups, but PAM was excluded from our analysis.
You have a question? Come over here. Or ask a question to me or ask a question to Christina. Yes, it does. Yes. The question is, what is the role of measuring the thickness of the tumors in conjunctival? Clinically, you mean, or histopathologically? Yeah, this is called Breslow method. There's two methods to do in the skin. One is described by Clark, one described by Breslow. And where is, Paula Blanc is not here. Breslow was or Argentinian. I know, nobody's perfect. But Breslow did something very important. Instead of going by areas of the skin, levels of the skin, when you deal with the mucosa, it's much more precise if you measure. Then we measure in microns or millimeters. Then there is some numbers that are important in the conjunctiva. The conjunctiva has another difference from the skin. If the tumor is nodular, then obviously Breslow is going to be huge, right? Breslow does not work for nodular tumors. And nodular tumors have a tendency to have less recurrence and less metastasis than not nodular tumors. Then the only tumors that you cannot apply Breslow method is nodular tumors of the conjunctiva. Okay? Thank you, Christina.
Thank you.
Okay, sorry.
So there is a huge clinical implication for thickness, because if the thickness is about more than 2 millimeters,
yes.
The Breslow is more than 1.1 something.
1.2.
Then they are the candidates for sentinel lymph biopsy. So we will do that for conjunctival. Also, presence of mitosis and ulceration are also important for pathology.
Very good.